Aziz and Muhammad will continue to work on that with all of you guys. It's our pleasure. First, I'm going to start by appreciation. I would thank PAMA institution for giving this unique opportunity for us to help and to volunteer, and for all of the other students to be participated in those programs. That's going to help for sure their career path, probably more than probably imagine at this point. Special thanks to Dr. Alturk. He was my mentor actually at University of Toledo when I did my residency. I was very grateful for the experience and the guidance he provided to me. And I can tell it was one of the best educational experiences I got in my life. Thank you so much, Dr. Alturk. We will first ask the question, why bother doing research? Because many of probably the audience, they have some kind of interest, but still they want to know if there's any strong reason why they should use their time to do research, because it is a dedication, it's part of your time, and you want to make sure that you have a good reason to do it. First, it's academic experience, and I can tell you, it's an educational experience. When you become a medical student, you are reading resources. Those resources, big part of those resources generated by literature, research. Once you start to be involved in this kind of research, you're gonna have a better understanding how they generate literature, what is the best way to understand the current concepts, what is the things that we should do, what's the thing that we should ask more question about, what are the things that we have to avoid doing. So being part of this process, I can tell you for sure, is gonna nourish your academic experience. The second thing, connection to the field. For example, if you are interested in a specific subspecialty and you want to work with the people who are part of this subspecialty, for example, you are interested in cardiology. So research is a good entry point to work with those guys. So you can start working with them, helping them, and then you will learn, you will start to be more helpful member of the team. And I can tell you, they will not forget that. They will help you at some point in your career. They can always recommend you. They can connect you to the very helpful people. So research, I would say, is a very good entry point for you to connect to the people in the field that you're gonna probably pursue in the future. The third probably point is boosting your CV, because as all of us know, like research is, and because we are in academics, you are studying in medical school, then you're probably gonna go to graduate medical education like residency or fellowship. Then one of the things that you will see in your life, once you talk to someone, the next step, the next question they're gonna ask you, please send me your CV. So you're gonna email them your CV. It will be far better if you have research, not because they're gonna judge you, because they get like CVs every day from other people also. So let's say that you have a good research on your CV, you will stand out because they talk to many people, they will get referral from many people. So you're gonna stand out for sure. Let's say that you do not have research, even if you are excellent academic student, you have a gap and you have a disadvantage in your CV compared to others. So it would be very smart to start to fill those gaps early, make sure that your CV will match other people when they send their CV, and maybe stand out. And one of the things that's also known right now, that research is a big factor when people extend your interviews when you apply to residency or fellowship training, because for example, the change that happened, that they're gonna change the step 1 into pass-fail, make it harder for the IMG to stand out unless they have other things like research. So there's many strong reasons why a medical student or early career resident fellow interested to do research. So to jump into research, I wanted to make sure that one of the things about research, it can be confusing. Like they're gonna start by big paragraphs, many outcomes, many stuff going here and there. It's gonna like kind of very confusing, but I wanted to make sure that you have a way to look at any paper the same way. You have a standardized way. So the research is, generally speaking, only three main components. Any research paper you pick, it should actually have three main components. The first component is the exposure. So the exposure is, for example, I'm gonna give you 2 or 3 examples. Let's say we are testing the effect of smoking on lung cancer in Palestinians. So the exposure is the smoking, and the outcome is lung cancer, and the study population is Palestinians. So despite like how much the research complex, New England Journal of Medicine, biggest study, you have to be able to identify what's the exposure, what's the outcome of interest, and what's the study population. And why this is important, even if you are not doing a research, this is important for a reason. Let's say that we had a study done in the United States comparing a specific medication, the effect of this medication on a specific patient population in the United States. One of the practitioners in Palestine may pick this study and say, oh, it showed a significant difference there, let's apply it here. It might be a trouble actually, because you have to be careful. You have to make sure that study population kind of like very similar to your study population here in Palestine. Like, so you should not, and this is one of the traps that I've seen many of the clinicians or researchers walk into. The thing is, they say the study said this, but when you go to details about what's the study population they tested, it's very different than what you are referring to, like your patients. So always try to identify, and this is a practice for everyone, a practice, always try to identify study population, exposure like risk factor. The exposure can be risk factor, the exposure can be medication, the exposure can be something not you assigned, something happens like without you deciding what's going to happen, like not a trial, like just for example, smoking. So always make sure that you identify exposure, you identify outcome like mortality, how many patients die, heart failure, myocardial infarction, what the outcome, and what's the study population, when and where this study was done. This is very, very essential, and this is you will go back to this every day and every time when you do research. So everyone probably saw this photo before, the pyramid of the evidence-based medicine, and what is the most important, the strong thing, that systematic review, and probably the least significant or important or contributing evidence is the expert opinion, because it's your opinion. It wasn't done in a standardized way. And the good thing about the meta-analysis, and this is the main reason for this course, is it is on the top of all of this pyramid. Actually, it is here. It is in the highest area. And that's the most important probably thing is it's the highest, it's here. So it's in the highest level of evidence. It is the best actually way to summarize the evidence. So this is why we are talking about meta-analysis. The other important thing, and you're gonna learn over time, that this is not necessarily right actually. So you will see that sometimes maybe a cohort study has a better quality than randomized trial. And this you will learn over time to understand how they did the study design, where's the problem in the study, what's the drawbacks, what's the good things, the bad things. So you will learn over time to start to understand what's the problem with every study. And we're gonna, when you start to do meta-analysis, you will start to understand the quality of the studies, because you have to report the quality of the studies as part of your meta-analysis. So you will start to learn more how those studies has high quality, this study, low quality, what's the good thing, the bad thing, that kind of stuff. So we're gonna start to apply the principles of research on the study, and we'll give some kind of like highlights for the medical students, resident fellows, and also early career physicians, why this is good, why this is bad, what we should focus on. So first, we're going to start by one of the most famous, actually, study type and research type, case report / series. The case report is only one case. Series is multiple cases. So what are they? They are kind of narrative. So they are always, you are describing how the patient came to you. Like just you saw the patient, you took a history from the patient, you are describing how the patient came to you. Then what you did, you or the medical team or the hospital system. Then what happened after that? Did your intervention work? Did not work? What happened after that? And then probably you can give some kind of literature review on the topic that you are covering. For example, if you are talking about COVID vaccine, let's say, in a specific population, you say in a liver, you have a case that has anaphylaxis in the COVID vaccine. After you get the COVID vaccine, you have anaphylaxis. You start to say, patient came to us, has anaphylaxis. Picture, then we treated the anaphylaxis, then we stabilized the patient, then we asked more history, and the only thing that the patient got was the vaccine. And then, you start to go to the literature to see if there is any other cases like this case that has been reported or not. So you can reflect on that and give some kind of helpful discussion, and you can provide some guidance for next steps. This is generally speaking what the case report. So the problem, what are the pros of the case report? The case report is helpful in many ways. First, it's easy. It does not require much training, much resources, much planning. It's easy. It's easy to be done. It's cheap. Does not require you to spend much money. You are not doing intervention. You are just getting the information from your patient and trying to make a reflection and write it in a good way so you can provide some kind of evidence or addition to that literature. And it is a good way to discuss new diseases or new presentation of a disease or a new treatment into medical literature. For example, the best thing about the case report, when you use it for rare cases, something there is not enough patients having this problem to have a big study. So the case report will be very valuable in that regard because we are the only thing is available. The other thing is when you are describing a new treatment, like something that you started. I can give you an example also. Like, for example, there is a new disease, for example, Zika virus or COVID when it started in China. There was no way to have a big study about it. It's a new disease and we don't know what's going on and we don't know what is happening. So any case report or case series was written at that time about this topic was very citable. Many people cited that case report or that case series because it's the only thing available. It's a new disease, it's affecting the healthcare system, and you didn't have much studies and you didn't have enough even patients in the very beginning and not even enough medications to treat that disease. So whatever you are describing in your case report will be very valuable actually in the literature. And there's many things in the COVID actually where the case report was cited 10, 20, 30, 40, 50 times or 100 times. And citation, I mean, like some other people took it as a reference. And that's a sign that this is important because many people is taking it as a reference. So it's important in the literature. And the fact that many people were able to get that citation tells you that this case report is important. And the reason why it's important, because there is not enough studies in the topic. It's a new disease, a new treatment, or new presentation of a disease. So always when you go into practice, even if you are a medical student, you have to go your clinical years to the hospital. You will see patients. Try to grab any interesting patient that has those either or new disease, new presentation, new treatment, and try to think about writing a case report. And one of the things about the case report, many people will say, Oh, it's not even a research. I don't think you have to write a case report. It's not even a research, because their argument is there is no research question. What? Because you don't have any hypothesis in your mind when you write a case report. You are just describing what happened. You did not have an experiment. You did not have an exposure and outcome in your mind to test your hypothesis, because this is what the researchers do. They have a hypothesis, and this hypothesis, they should test it with the research, either to approve the hypothesis or to reject the hypothesis. But here's the thing. Case reports are very valuable for hypothesis generating. So, for example, you have a case like essential thrombocytopenia, for example, and from COVID, let's say, and you have this observation 1 time, 2 times, and you notice that you did IVIG to treat the patient, or steroid. Some other people tried some biological therapy. Then one researcher will come and say, oh, I see case report said this, I see case report said that. How about I start a hypothesis to know what kind of the best treatment for this condition? So they start the clinical trial, for example, based on the case report that reported those findings. So case reports still are important for hypothesis generating. The other thing that you have also to ask yourself a question. Always you have to ask yourself a question. If I look at your CV and I saw 3 case reports, or I looked at your CV, I did not see any case report, because you didn't think that this is a research, and you're still waiting for a research opportunity. Who I'm gonna like better, the one who has case reports or not? For sure, the case report, because it's a research experience, and they have to submit to journal, and they will get that experience from the journal and the publication, and they will get to respond to the authors and the review process. So they get into all those milestones for publication, and those are very important milestones to learn. So if you publish any case report, you'll go through this process. And if you go through this process, the next time will be easier. So if I'm a researcher, I'm gonna pick the one who has the case report for sure, because he or she will know better the publication process than someone who did not do any case report. So do not underestimate the strength of case reports, especially if you are early in your career. You do not have much resources to do a big research. You don't have the experience yet. Start step by step, one at a time. So what are the cons? Because there's cons for sure for the case report. First, there's no comparison group. And this is a big trouble actually in research. So when you're trying to test a hypothesis, always or almost always, you have to have controls. What that means, like if you are testing if the exposure, like smoking or a medication to treat with fatty liver disease, those exposures, if you want to make sure they are working, you have to compare people with the exposure versus people without the exposure, and if there's any difference in the outcome, like mortality or whatever. So comparison is essential in research, and it's not happening in case report. So this is one of the biggest weakness point in the case report. And the other thing, you may actually have some kind of case report in a way. When you do the literature, you can use historical case report, like what, for example, you can say we tried this new treatment for the patient and it worked, and you can reference that the previous cases that did not use the treatment has higher mortality. So you can make a case still, but it will not be that strong. So the bottom line, case reports are a great starting point. You should not underestimate the case report. And case report can be citable if it's something important. And they are good for hypothesis generating. So they can help you or guide you to understand what you can do next research-wise. And the other thing is about the case report, they are easy to do and they do not require that much experience, but they provide you with the experience and the publication experience. So I always think that case reports are valuable tool once you start early in your career and you want to have this research experience. I think they are valuable and we should not underestimate them that much. The next type of studies, and also it is kind of simple and you can do it, they are cross-sectional studies, or what we can call them, some people call them prevalence studies. So the prevalence is to simplify it, what's the prevalence of, for example, heart disease in Palestine? So what you do, you have to, it is simply, you divide the number of patients who have heart disease, whatever it is, you can say just only cardiovascular disease in general, or you can say heart failure, on the population of interest, which is, for example, the total population, or the adult population, or male population, or female population, you can decide. So this is the prevalence. This is the prevalence, like give you estimate how much the disease in this population. The difference between prevalence and incidence, also you may hear the word incidence. Incidence is how many new cases every year. So it is more every year new cases, but prevalence is more like how many patients have the specific outcome of interest in our population. So generally speaking, they are, so the prevalence study or the cross-sectional study, you can simplify it and say surveys. Generally speaking, they are survey study. You go, you pick a random sample, for example. And for example, I want to see patients with the effect of smoking or lung cancer in Ramallah. So your study population, Ramallah. And then you can specify it more, male, for example, and adult, more than 18. Then you can take random sample from specific, there's many ways to do the random sample. We'll not go into it right now, but there's many ways to do random sample. And then you pick, let's say 100 or 200 patients. Then you go ask them a questionnaire, ask them, do you smoke? How much do you smoke? Do you have any history of lung disease? Do you have lung cancer? Whatever. And then you try to divide the sample into two things. One with the exposure of interest, which is the smoking, and the one that does not have the exposure of interest, which is no smoking. So, and then you see how many patients in the smoking group has the disease, and how many patients in the non-smoking group has the disease. And then you can tell, oh, I can see that the smoking was like the lung cancer cases in the smoking group was far more than the lung cancer in the non-smoking group. So you can conclude that smoking is associated with lung cancer. And so here is, what's the exposure? The exposure is the smoking. What's the outcome? The outcome is lung cancer. Then if you pay attention here, and what's the population? Male, adult in Ramallah. Then you have study population, you have exposure, you have outcome, and you have comparison group here. You have a group with no smoking and the group with smoking. And the other thing here, you are doing exposure and outcome at the same time. What that means, that you go ask the people about their exposure, like the smoking, and you ask them about their outcome, which is lung cancer, at the same time. So you are getting those two pieces of information at the same time. And this is in cross-sectional studies. So it's very easy to be done because you don't have to wait anything. You just go, you ask random sample, and the fact that you got a random sample from the population of interest can help you to get idea what the prevalence is, because you got 200 population, you can know the prevalence of smoking because you know how many people in this group was smoker, and you can also know the prevalence of lung cancer if this random sample is representative into this neighborhood. And this is like a complex thing. We'll not talk about it right now, but it is a way how to think about cross-sectional studies. So they are, in simple words, they are prevalence studies, exposure and outcome at the same time. and only one point of time, so you are not waiting. And why I'm stressing on this, with the other types of studies, they are done over time. So we'll just see. So this is only one point of time, and and you can get some kind of the prevalence and your comparison group. So as we said, after you get the number of patients, you can also put them into exposure or no exposure group. And this is a presentation of the study. So there's exposed and there is no exposed.
Hazem, let's give you a minute to get maybe water.
Or water.
Yeah. And
Sure.
I want to thank everybody. You guys have been doing great so far. Everybody is muted. We're not having any, background noise. So thank you very much. And the presentation to continue, just want to give Hazem the opportunity to take a sip of water. We'll be sending a Google form in the near future to fill your information, so we can use that for the certificate. So we'll need your email. Already we have this information, but when I looked at the Google Forms, some people they put their first name to be able to issue a certificate. I think we need full name, and it's very important to attend the 6 sessions in order to get the certificate. So please make sure to do that. Hazem, you're back.
Yep. And so for as we said, so the cross-sectional study, we are trying to see this is the timeline. So what we are doing right now, this is the study start time. This is the study start time. And we see in the exposed group, what was the outcome, and the non-exposed group, what was the outcome. And all of this done at the same time. So you are not waiting for anything. And this is important. We'll talk about later in the other types of study, why this is important. So what are the pros? They are fast. You just develop a survey, or you can take something we call standardized survey, and then you can use this standardized survey to ask the people the questions, and they'll give the answers. So it's inexpensive. It does not cost you much. And there's no loss of follow-up because you are not following up people. It's only one single point in time, and provide prevalence information. So those are big pros. What are the cons? The cons are hard to determine cause and effect. So that's interesting, actually. So one of the problems actually with this kind of surveys and like this kind of studies, that you are asking about the exposure and the outcome at the same time. So for example, you wanted to understand the risk or the relationship between obesity and diabetes. You go pick people, random sample, as we said, and you go ask them, do you have obesity? If they say, like, what's your body mass index? They will say, for example, above 30. Or what's your weight? What's your height? I will calculate your body mass index. Above, let's say, above 30, you have obesity. Then you ask them, do you have diabetes? Oh, do you have hemoglobin A1C? They would say, yes, you have the hemoglobin A1C, or they have diabetes. Then you will make a conclusion, say, obesity is causing diabetes. You cannot say that. The reason why, because you do not know what happened first, the diabetes or the obesity. So that's the problem with this kind of studies, because they are taking the exposure and the outcome at the same time. And ideally, if you want to make a relationship between exposure and outcome, you have to make sure that the exposure happened before the outcome. You want to make sure, if you want to establish any causal relationship, you have to make sure that the exposure happened after the outcome. So in this study type, this cannot be done. There's no way to do it, actually. So you cannot make any causation, but you can still report association. You can still report association. You can say obesity is associated with diabetes, but I'm not sure which affected what. It's hard to tell. We need further studies, like one of the studies that we're going to talk about later. So as we said, there's no time component. All of the studies, all of the measures, the outcome and the exposure taken at the same time. So you cannot say which happened first. And there is also high risk of confounding and bias in this kind of studies because they are not controlling for the bias and for the confounding. And just give you some kind of understanding what confounding is. Let's say that you have A related to B. For example, one of you guys wanted to do a study comparing coffee, which is the exposure, coffee exposure, to outcome, which is lung cancer. So, so you can say, oh yeah, my study, I've noticed that coffee is associated with lung cancer and people should not drink coffee because your numbers, and you are right, your numbers showed that actually. Because you went with a survey, you ask the people, do you drink coffee? How much you drink? They're gonna report, oh, I drink, for example, 10 cups. Then you would say, okay, people who has drinking 10 cups per day have higher risk of lung cancer compared to people who does not drink that much. So you can establish a relationship. Then you send it to the review journal. So the review journal will tell you, did you control for confounding? You will say, oh, what is that? What's confounding? We don't know. So confounding is, there is a factor called C here, connected to the exposure and connected to the outcome, but you did not address it, like smoking here. For example, people who smoke tend to drink more coffee, for example, compared to the people who don't smoke. So smoking was the real association and not coffee. So coffee, so if you control for smoking, like what's the meaning of control? Control, like you make sure that the two groups you are comparing are the same in regard to smoking, then you will not have any association with coffee compared to lung cancer. So confounding is a big trouble here in this kind of studies because you cannot control, you may control for it, but it is hard because you have to do random studies. You don't know upfront what groups you just go to random sample first, then you have to, through the surveys, you can split the group. So it's very hard to control for confounding in this kind of studies. And this is one of the big drawbacks of this study type. Then bias, risk of bias. And for example, recall bias. So, and this is common actually, and you will see it in in your life, if you think about it. And this the classical example of this kind of bias is the folate relationship to pregnancy adverse event. They always find that when you ask any mom who got any kind of kid with birth defect, that she gonna report that she did not take the folic acid, for example, or she took it late, or she did not take the right amount of dose. So it is, and people tend to do that because people, generally speaking, they tend to connect, they want to search for a cause for the outcome. People tend to connect outcomes to something. So if you ask people who have lung cancer, like not probably lung cancer, if you have the diabetes, for example, they will, like, for example, tend to report steroid use more than the people who does not have diabetes. So people try to, in their subconscious, to blame it on something, or they also sometimes tend to, people who have positive outcome, they tend to relate it more to the risk factor. So here it is hard to control for this kind of bias. Detection bias is more you as a clinician. For example, you're gonna try, when you are a clinician, to make sure that your patient who has BMI above 30, that they have bad health habits. You're gonna dig more, ask more questions, subconscious. And then the people who has healthy BMI, you're gonna try to say, oh, they're having healthy habits. This is how the people think, and this is something common. So to fix the confounding, you have to do something called control for confounding. And this is out of the scope here, but it is something you may read in the studies. You have to look for how they control for the confounding and what confounders they looked for. And to fix the bias, you have to do blind studies. So you as a researcher, you don't know which is what, and this is hard to achieve in the cross-sectional studies. So those are the big problem with the cross-sectional studies. They are good studies. They are great studies for also hypothesis generation because they are cheap studies. You don't have to pay much money to do this kind of studies. You just do it and you get some kind of information, and this information will help you to further guide your management after that. The case control studies, what are they? So they are starting, and this is important, guys. This is important, and this is important this is important why? Because when you do meta-analysis, you have to read every study that you are including or excluding. And if you are including the study, you have to know what is the case control mean, and and how those studies were designed, and how to look for the outcomes in them. So this is important when you do the data extraction or reading the studies, when you do the meta-analysis, because in short, meta-analysis is summation of the literature in a statistical way. So to do that, you have to understand different kinds of studies and how they report the outcomes and what the shortcomings of those studies. So generally speaking, ideally, let's say, if you want to make a good relationship between a good causal relationship, as we said earlier, you have to start by the exposure, then outcome. In case control studies, you start by the outcome. You don't start by the exposure. And this is one of the interesting things about it, because it is not naturally, you should start by the exposure. Then you look for the outcome. And this is how things should work. Here, we don't do that. And we'll see why. So you first go to see if there is any patient with a disease. Oh, like you search for a patient who has myocardial infarction or patient who does not have myocardial infarction. So you divide the two groups based on the disease status, not based on the exposure status. Then you ask about the exposure in retrospect. So for example, you go to people who have myocardial infarction, and then you ask them about their lipid intake, for example, or dietary habits, or smoking, or whatsoever. So you're trying to see what kind of exposures they had based on this outcome. And then you generate odds ratio, and it is one of the, and we'll talk in the second lecture tomorrow about the odds ratio and the difference between the odds ratio and the relative risk, and why in these studies we cannot generate relative risk. We have to generate odds ratio. We'll talk about what we call it a measure of associations. So here we're going to the outcome, and there is no outcome. Then we see exposed and exposed, which is against the natural thing that should have done. What should have done is you start with the exposure, then you go to the outcome. So many of you will ask why we do this kind of studies. There's a reason, actually. We'll talk about why we are doing this kind of studies. What are the pros? So they are good for rare disease. So that's important. Let's say that you have a disease like biliary cholangitis or primary biliary cirrhosis, something like that, something that you don't see quite often, something you see it only once every year, let's say. Then you're gonna do a study that starts with the exposure. You have to bring millions of patients to get 10 cases at the end of the day. Like you have to start with millions of people studying the exposure for million, and you have to wait for 10 years probably until you get 100 cases of biliary cirrhosis. Then you say, oh yeah, the exposure is associated or not associated. So it's very unpractical. So what you have to do, ideally, you have to go to the disease of interest, which is the biliary cirrhosis, because it's a very rare disease. You can do case control study. You just go to the people with the disease and ask them the question about their exposure, and that's it. So it's far easier in these cases when you have a rare disease. It is also short and expensive because you also just go to the people. You first decide those two groups, then you go ask them about their exposure. So there's no much time. You just first start with the group and the control group, then you ask both of them about the exposure, and then you have the odds ratio, and you can say, oh yeah, this exposure A is associated with outcome B, because the disease was more in the group A compared to group B. And it is also good for hypothesis generation because it's cheap, it's easy. So you can start with it actually sometimes. And after you get kind of understanding, oh yeah, you just go for example, liver disease, fatty liver disease. You just start by case control. You just grab 100 people who have non-alcoholic fatty liver disease. And then you say, those 100 patients, what kind of exposure they had. So you know that alcohol, okay, there's alcohol exposure was significant in the fatty liver disease. I will not say non-fatty, no, metabolic associated fatty liver disease. So in this population, alcohol was more compared to the other population. Then you can start another study. We'll talk about it in a second, and start with the alcohol exposure and see how much of them they will develop the disease. So it's a good step sometimes, and the only thing that you can do sometimes. You cannot do much, actually. It's the only thing that you can do. So it is still usable, it's still something you can use. The cons of it, it's bad for rare exposure, because the same thing, like if you have a rare exposure, like something does not happen quite often, then if you do a case control study, you get 100 patients with a disease, maybe none of them get this kind of exposure of interest. So your study will fail. So in that situation, ideally you have to start with the exposure because it's the rare thing. Generally speaking, we start by the rare thing because it's easier to find. Then we go to the common thing, because if you start with the common thing, you not start with the rare thing, you start just with the common thing, you will end up without any results because you will not get that rare exposure or the rare outcome. So if you have a disease with the rare outcome or rare exposure, you just start by this rare outcome or rare exposure, and then go backward or forward. And all the data, again, all the data actually collected at once. There's no time component. And if you don't have a time component, then you have a trouble establishing causality. Like again, you go to liver disease, for example, and you say, oh, there's association with alcohol, but you cannot say alcohol caused the liver disease because you ask the patient about the liver disease and the alcohol at the same time. So you don't know what happened first. I know it for sure, it makes sense that alcohol, yeah, causes the disease, but if you send it to the reviewer, they will say you cannot make this assumption unless you have a time relationship. So temporal relationship, and there is some, we'll not talk about it right now, probably, but over time we'll probably bring this up again. What things in the study that can help you establish causality or causal relationship? One of them, the time component, is very important and cannot be used to determine prevalence for sure, because and you don't have to probably to dig much about it. Just remember always, guys, cross-sectional studies is the studies of the prevalence. Just always remember this. Cross-section is the only study that you can actually determine prevalence through it. Only study. And there is a risk of confounding, and this is, you will see it in the literature a lot, actually, a lot in the case control studies. They will say we picked the cases from specific hospital and we picked the controls from other hospital, and those are different because one of the cases are from rich hospital and the controls are from the poor hospital, so you cannot make a relationship. So, and this happens a lot, but there is a way to avoid that. Actually, you can do something we call matching. So there is a way to avoid this, but I saw many published papers actually that they have this mistake, and maybe it was hard for them to do it the right way. So it's a limitation of the study, but you as a reader of the literature, you have to understand those limitations always. You have to know how that fit, because you shouldn't take it for granted. Say, oh yeah, they have been doing a great job, that's it. No, you should read and understand if this is limitation or not in the study. So confounding is a big thing. One of the most interesting studies, actually the cohort studies, and those are the natural, like the most like natural studies. So you start by the exposure. You start with a group with exposure, a group with no exposure, and then you say, oh yeah, the group, and you can see after that the outcome of interest, if it's the same in both the groups. So it is the natural way to do it actually. And it is helpful to get the relative risk. So also it is very good because it gives you incidence data. Again, what's the incidence? Is the new cases of the disease every year or every timeline, depending on what you are doing. So here you start with the exposure. No one has the disease, both the groups, no one has a disease. Then you follow up them with this patient for 1 year, 2 years, 3 years. In the 3 years, the exposure group got 10 patients have the disease. In the non-exposure group, you have only 1 patient got the disease. So the incidence in the exposure group higher, more patients develop over a specific period of time compared to the non-exposure group. And this is called the incidence. And the incidence is the thing that you use to calculate the relative risk. And that risk is more actually relative risk, and this is kind of a fine detail we'll talk about a little bit late tomorrow, inshallah. It is a better way to compare the association, to understand the association compared to the odds ratio. So, and there's 2 types. There's prospective cohort and there's retrospective cohort. And I think many people confuse the retrospective cohort with the case control studies. And they are one of the most helpful studies that I think everyone should understand. So prospective cohort, you have, this is the time component here. You start by exposed and non-exposed, and then you see the outcome, the percentage of the outcome in both the groups. And if the percentage of outcome in the exposed group higher than the percentage of outcome in the non-exposed group, you can say, yeah, there's a relationship between the exposure and the outcome. And this is very good to establish causality because it's a temporal relationship. It was a time component. We started by no disease here. Both of those 2 groups has no disease, both of them. And then we'll see how many develop the disease. So it's a very, very, very good one. The problem with it, it will take time because you will have to wait years sometimes to get your outcome. So for the retrospective cohort, and that's the good thing about retrospective cohort, you do not start here, your study, you start here. So for example, you go see, like you start to see, for example, smoking again. You do not, for example, in smoking, it's retrospective cohort because you cannot do prospective cohort. You cannot say, please smoke for 10 years and we'll see if you have a lung cancer. You cannot do that. So you go to the people who smoked for 10 years and the people who did not smoke, and then you go backward. You see if they have any lung cancer or not. Or people who has been taking a specific medication, let's say, for example, like finasteride. You go to the people who have finasteride, like one of the anti-androgenic medication, and people who did not, and then you check them for osteoporosis to see if there is any osteoporosis or not. So you will see if they have outcome or not. So here you don't start by the osteoporosis. If you want to convert, let's say here you have finasteride, the medication, osteoporosis as the outcome, let's say. So if it's a case control study, you go to the osteoporosis group and divided by two groups, depend if they have finasteride or not exposure. So you start by the outcome actually, and then you go to the exposure. Here you start by the exposure. You start from here. People who has finasteride or did not have finasteride, then you go backward to see if you have osteoporosis or not after that in the charts, for example, or you can ask the patient. So the big difference between this study and the case control study, in the case control, you start by the outcome. You start by the outcome, disease, no disease, and then you go backward to the exposure. Here you start by the exposure, and then you look for the outcome. Which is better? For sure, starting with the exposure, because it's the most natural way, and it's far more better to make to establish causality. And by the way, this is one of the, I think, the most common study type in the literature, and one of the most, it's the most abundant actually type you can see in the literature and it can be used in the meta-analysis. We have to understand this, and as we said at the very beginning, exposure, outcome, study population, that's the most important. If you can define those three components in the study, you will be able to understand this is case control, this is the retrospective cohort, prospective cohort, cross-sectional, and this will help you when you do the meta-analysis a lot.
Please.
So there's
okay. Prospective cohort study is unethical due to the forcing the participant to be exposed to the disease. Yes or no?
Depend on the exposure. So if, let's say the exposure is so actually here's the interesting thing. In the cohort, so the difference between the courses and the next step will be the trials. You do not control the exposure. They are exposed by themselves. You do not ask them to have this kind of exposure. They are exposed by themselves. For example, people live in a neighborhood that where they have near like some kind of environmental hazard, and they are living there, and they continue to live there for 5 years. You do not ask them to stay there. You just follow up them. You follow up. If they stay there, you say this is exposure, and you compare them to people who did not have the exposure. But in clinical trials, it's unethical to force, because in clinical trials you do the intervention. It's unethical to do this kind of interventions because you are harming the patient. But in the cohort studies, you are not controlling the exposure. The exposure is there.
Okay, thanks.
So just last two things before we take probably a break for the studies. So as we said, the cohort studies is good for rare exposure and provide time sequence. And there's no recall bias because you start by the exposure, and provide incidence, as we said, and it can also do things that you cannot do with a clinical trial, like the unethical stuff. Can be cheap and fast, like the retrospective. The cons are sometimes if it's a prospective, it's very expensive, very hard to do. It needs a big number. And the problem also, again, this is also answering the question, loss of follow-up, because you do not control actually the exposure. So the people can always stop the exposure. So you just say, oh, this patient is out because he is not exposed anymore. So you do not control the exposure. Sometimes it's also hard to control for confounding, because the best one is to control, because one of the ways to control for the confounding is the randomization. And here you cannot randomize because you cannot control the exposure. So I will stop. This is probably the first part. This is the first part. We'll talk more about the other part, questions. And Dr.
Thank you, Hazem. This is really fantastic review about what are the type of different studies. And I was taking some notes from the chat regarding questions. There was a question about co-founders. How to control the confounders?
So for the confounders, first, I will try to go back again about the top, like what's the concept, because this is very important. You will see it quite often. Let's say A go to B. So this is, you think that, as we said, coffee is associated with like lung cancer, let's say. You assuming that this is the relationship, which is not the case, because there is a C you did not ask about, and it was there, smoking. So smoking is associated with more coffee drinking and associated with more lung cancer. So if you control for the smoking, this relationship will not exist. So here's the question. What is a control? This is the question. Controlling, there's many ways to do it. One of the ways to do it in the non-randomized trials. Randomized trials, there's easy way to do it. But for the non-randomized trial studies, like the other types of studies, you have to do something called matching. So what the matching is, or like this is so you can actually control for it in the design stage of your study, and you can control for it in the analysis stage of your study. So for the design stage, you can say, I want to make sure that all the patients in the group A, like the coffee drinker, and all the patients who are in the group B, the non-coffee drinkers, have the same smoking amount. They are the same. The smoking is not different between two groups. They are the same. They smoke almost, the average is the same. Like the group A, they smoke, let's say on average 10 packs per day, and the group B smoking 10 packs per day. And how you can do that practically, there's some statistical ways called the propensity score. It's kind of like, but you can do it, like whatever. We'll not talk about much how the statistical way to do it, but there is a way to do it. Like you can for sure make sure that your study population is matched before you start your study. So you will know for sure that the smoking is not a factor, they are the same. And if you look to any study, there is a table 1. Table 1, there is something we call basic characteristics. In the table 1, they will list many things, age, gender, whatsoever. And then they're gonna give you a p-value there, p-value after they put the two groups. If the p-value is non-significant, that tells you that they did a great job in matching the two groups. There is no difference in those baseline characteristics. So those will not be a confounder. If there's a p-value significant, for example, smoking, there's a significant difference between the two groups. You have to control for that in the analysis because you failed to do it in the design. So in the analysis, you can easily, when you do the statistical approach, to control for the confounder. For example, if you are doing logistic regression, you can always control for confounding in the models. It's easy, and we probably can go through it. If you have a randomized controlled trial, then you will not have a confounder. The reason why? Because it's randomized. You are randomized the people into two groups. You are distributing the confounders equally between the two groups. So there will not be a confounding because you are distributing the confounders to both the group the same, because it's a random process. You do not actually decide who get what. And this is the beauty of the randomized controlled trials for the confounders.
And in the analysis phase, it's the adjustment of confounders.
Exactly. You do like, if you look at any study, sometimes they report something we call raw odds ratio, and then age adjusted, and then BMI and age adjusted. When you go for logistic regression, for example, you can make multiple models, and you can know which one is affecting your outcome. So you report that as a confounder, and you report that model. I adjusted for age, I adjusted for example, and age is the most common actually confounder you can see in the literature. I adjusted for smoking.
Excellent. Before we keep going in the question section, please make sure to fill the Google document form that I sent in the chat, so we can, get the attendance, because this is really a big group. I am very excited about, the participation. There's a comment from Dr. Randa Zakut, who, by the way, was my classmate in Al-Quds University, and she's one of the smartest physicians you can think of. She is certainly smarter than me. So she commented about case control study. Yes, we can define causality relationship, but it's helpful to in defining risk factors. Exactly, I think this is really important point. Always, even when you are writing case report, thinking about, is this real association between medication and let's say, a side effect, or is it an incidental finding? So always try to get an idea about what could be other confounders. This is, unfortunately, it's something inherent in any clinical research if there are confounders. There's a question about, can you please re-explain how case control studies are different from retrospective studies?
Sure. So for the case control studies, and if we go back to the case control studies, because this is important, actually, I think this is one of the most important things in this presentation. So the case control, you start with the outcome. So when you define your groups, you just ask, you look for two groups, one with the disease and one without the disease. So this is how you define your groups of interest. Then you look in each group to see how much exposure they got. For example, you can go, for example, myocardial infarction group and people who did not get myocardial infarction. And then you ask them about statin use. Did they get statin? They did not get statin. And then you can make a relation. People who got statin has less, less ability, less odds ratio. You cannot say actually incidence. They have less events of myocardial infarction. So you start by the disease. You don't start by the exposure. In the retrospective cohort, you go, for example, and I give you a practical example. In the hospital, you go to the hospital records, for example, and then you look for the exposure. You define your population based on the exposure. So you go to the people who got statin and people who did not get statin. So you define your group. The first group is the people who got statin, and the next group, the people who did not get statin. Then you look in the chart to see if they get myocardial infarction. So you start by the exposure, and then you see if they develop the outcome of interest. This is like the difference probably in this like very practical example.
Okay, great. Lama is asking, what are the types of research or studies that can be used in systematic review?
So systematic review alone, you can do anything. You can use anything, actually, even in case reports. You can use it in the systematic review. But meta-analysis, no. Meta-analysis is different. And we'll talk about it probably later. But systematic review, you can even, and there's many case report actually. And I know there's one, one of my colleagues did very recently. It was only case reports, systematic review, the whole of it, and was accepted in a good journal because it was a rare disease. There was no big studies done on it. So this is also going back again to the importance even of the case report for us. Sometimes we have to do it. So in the systematic review, any kind of study can be involved.
Great. And I think we'll take the last question. What's the difference between confounders and effect modifier? Muhammad is asking.
That's a great question. Even it is maybe a little bit advanced, but let's do it very quick here. So again, A, B. So, and there is a C. So I will try to answer it in a short time. So if you control for C, if a C is a confounder, so let's say I did the study and then I concluded A is related to B, okay? A related to B. Then I will say, yeah, A is associated with B. And there's a significant p-value there. We'll talk about p-value probably tomorrow. So if the reviewer asked me to do adjustment and control for the confounding, so you controlled for the C, then the relationship disappeared. There's no relationship anymore. There's non-significant relationship anymore. This is confounder. This is confounder. Let's say that you adjusted for it and the relationship stayed there. There was still a relationship. This is effect modification. This is the effect. This is a big difference between these two. And the effect modification is very interesting topic because actually you can classify after that, you can divide or classify your outcome based on this effect to give some kind of, because this is interact with the exposure. It's interact with the exposure. So this is what was the effect modification. If there's no relationship, this is confounder. If there's change in the relationship, this is effect modification.
Excellent. Hazem, certainly I enjoyed very much your talk, and I hope everybody enjoyed also the talk. Again, please make sure to fill the Google document form so we can, have an idea about the attendees for this session. And I appreciate your time, everybody. Thank you very much, and have a blessed day or night. Thank you.
Thank you, Dr. Alter. Thank you.
Thank you very much.